So our next speaker, as I mentioned, is Dr. Lisa Nachtigall, who is visiting us from Boston, from the Massachusetts General Hospital. She did her medical school training and residency at NYU, and then her fellowship at MGH, and she's an integral part of the Neuroendocrine Center. She's the co-director of the Neuroendocrine Clinical Center there, and she has done a lot of high-impact research, really well known in the field of acromegaly as well. And with that, she's going to give us our first talk on pitfalls in pituitary tumors. Dr. Nachtigall, thank you.
Thank you so much for that introduction. You know, it's funny, I always wonder what the podium is going to look like, because even though I'll be talking to you later about gigantism, I don't think any of you can see me here. So we've learned a lot this morning, and I want to thank our course directors and our sponsors and the USC administration for allowing us all to be here and learn from this. This talk is going to end the morning before lunch, with a time for you to kind of think about what you've learned about the pituitary, what the other course informants have taught you, and put them into practice with real cases that have challenged me over my career. So this is these are all true cases. A 60-year-old woman comes in with diabetes from an outside endocrinologist, and she's referred to me by our neurosurgeon because he found that she might have a pituitary lesion. So I took her history. She has diabetes, a long time ago breast cancer, and she's been on prednisone for polymyalgia rheumatica for a long time. 1 year ago, she started feeling very thirsty, having increased urination. And just a few months ago, her endocrinologist thought, you know, this might actually be diabetes insipidus. Let's start DVAP. And then I met her, and she looked cushingoid because she had been on a lot of steroids, but otherwise no real problem with her exam. She did have a little bit of a right ptosis. And this was her MRI, which, you know, had been billed to me as a non-functioning adenoma or a cyst or a Rathke's. And there you see it. And we just wanted to make sure that she had DI, so we did a bunch of tests off her medicine. We proved, as you can see, that she did have diabetes insipidus with an elevated sodium, and her urine osmolarity was low. She also had some mild increase in liver tests, but she had diabetes and was obese. She did have, as John has already taught you well this morning, obvious central hypothyroidism with a suppressed free T4 in the setting of an inappropriately normal TSH, a low cortisol and a slightly low IGF-1. Well, it turns out before the pituitary surgery, luckily I said, you got to investigate some of this stuff, and she had